Pneumonia. Pneumonia is defined as acute inflammation of lung parenchyma distal to the terminal bronchiole. Classification: pneumonia. Pneumonia on the basis of anatomical region: lobar, bronchopneumonia, interstitial, and pneumonia. On the basis of clinical settings: community acquired, hospital acquired, ventilator associated. On the basis of etiology: bacterial, viral, fungal. Lobar pneumonia. Lobar pneumonia is an acute inflammation of lung parenchyma which affects a part of lobe or interlobe of one or both the lung. Etiology: pneumococcal. More than 90% of all the lobar pneumonia are caused by Streptococcus pneumoniae. Staphylococcus pneumonia. Staphylococcus aureus cause pneumonia by the hemorrhaginous spread of infection from another focus. Streptococcal pneumonia. Beta hemolytic streptococci may rarely cause pneumonia in children and in diabetic patients. Pneumonia by gram-negative aerobic bacteria. It is less common cause of lobar pneumonia, which may include gram-negative bacterial like Haemophilus influenza, Pseudomonas E. coli. Pathogenesis. In lobar pneumonia, following stages are seen: stage of congestion, grade hepatization, resolution. In lobar pneumonia, part of the lobe or whole lobe or one or both the lung may be affected. Stage of congestion, first to second day. It represents the initial stage showing acute inflammatory response to the bacterial infection which lasts for 1 to 2 days. The affect lobe in large, heavy, dark and congestion. Red hepatization 2 to 4 days. This is the phase of early consolidation which lasts for next 2 to 4 days. The term hepatization in pneumonia refer to the changes showing liver-like consistency of affected lobe. The affected lobe is red, firm and consolidate. Its microscopic picture show presence of numerous RBC and neutrophils. Grey hepatization 4 to 8 days. It is a phase of late consolidation where the affected lobe is firm and heavy. It cut surface in dry, granular and grey in appearance. The changes is color from red to grey begin to hyaline spread toward the periphery. Its microscopic appearance shows the presence of clear space along with the dense firm alveolar some macrophage. Resolution 1 to 3 weeks. This stage begins with around 8 to 9 days and gets complete 1 to 3 weeks. However, if properly antibiotic therapy initiate early, then we can get fast result. Microscopically, this phase there is a presence of congestion, numerous amyloid, macrophages and lymphocytes. Clinical feature. Classically, the onset lobar pneumonia is sudden. Its major symptoms include fever, pleurisy, chest pain, dysphagia, sputum containing purulent or blood discharge, cough with expectoration, decreased oxygen saturation. Investigation. Blood investigation, leukocyte which markedly cause neutrophil raise ESR. Sputum examination for culture sensitivity and staining of the infective organism. Chest radiography. It may show consolidation, change in solidification of lung tissue in affected lobe of lung. Treatment. On administration of proper antibiotic, the response is usually rapid with clinical improvement seen in 48 to 72 hours after the initiation antibiotics. The broad spectrum antibiotic used in case of lobar pneumonia include cephalosporin, streptomycin, azithromycin, levofloxacin. Complication of lobar pneumonia: lung abscess, pleural effusion, pleuritis, inflammation of pleura, emphysema, pus in the lungs, septicemia.